Good evening, everyone. I think my slides are sharing and I'm audible.
Yes.
Yeah. So today this module will be on the result interpretation. Hello, am I audible?
Yes, sir, you're
You're
audible, sir.
audible, sir.
Am I audible?
Yes, sir, you're audible, sir.
Okay, sorry. So today my topic was to do this module on result interpretation, and over the last few modules, I have seen that the last module was about what test you want to do, what would you order, what are the techniques, what are the pros and cons of each technique. So after you have this, and then you have a report. My job in this module is to take a few important reports, what we do in our daily practice, and look at are we really interpreting the report as we should do, and is this something which we can do better and learn better. So the flow will be interpretation of the common test. The clinical relevance is what I'll be vouching upon, but that's what we as clinicians are. And the last part of it will be a small slide on how to choose a good lab. But over the period of what I'm going to speak, definitely some parts of that will be touched in every slides. So let's come to something which is a very common thing, which is normally done. Do we really think so much into this report? Is something I would like to share. This is the estrogen receptor and the progesterone receptor report. What we do for every breast cancer, we do it beyond breast cancers now. And this is a HER2 new report also there for you. So what do I look into this report? When I have a report, what do I see into it, and what as a clinician should I see? So actually you should see what you have ordered for. Is that being done? And the important part here is, do we have a lab which is NABL accredited, and does the test which you have ordered in the scope of the NABL? That's important, because I found a lot of NABL labs could be the scope of them could be some 10 tests, but they would be reporting 20 more which are not in the scope. So to look at whether the test done is in the scope is so very important. Then I look at the site, and here you find the site is not mentioned. I do not know it's a breast. It could be endometrium. It could be anything, because we do now estrogen progesterone receptors beyond breast. So that is something which you have to go back to the pathologist. This is important. We look at 5% cells that we have done, and anyway, this interpretation will be that it is positive. And I'll come to why this is positive and what your interpretation should be. It is because the nuclei have stained to the 5% classifications. We have HER2 new, which is also positive. But in addition, I think additional qualification does matter. And the CAP accredited lab, you feel more confident it's NABL lab, it's a CAP accredited. So now coming down to interpretation of the report, anything beyond 1%. Look at this ASCO guidelines and the College of American Pathologists guidelines. Anything beyond 1% is told to be positive, and that's what the report was all about. And the beauty of ER is you have an internal control. The slides have normal epithelial cells. They also pick up the stains, and that is normally the internal control. But you also could have external control, and they do both of it. And you should in a report look at it, whether the staining was there in the tumor tissue and whether the staining was also there in the internal and external control, because to have a staining in both, at least in the positive control, is so important. Otherwise, this report has to be questioned if you do not have the controls being tested. And this is very, very important, because in spite of 30-40 years of oncology, all of us doing this ERPR report, still a lot of us do find this being fallacious. I do find still in my practice, ERPR is not done to the standards, and people do not follow the standards. So look at the 5%. Come back to the case. Does it have a predictive and prognostic value of the low estrogen receptor expression? Look at the conclusion. I took a paper from Currents of Oncology. This is a Canadian research paper. You can find lots of paper in this. I've just picked up one example where they looked at beyond 10 and below 10. And if you look at it, they looked and found the graph finds that if you are below 10, and if you look at it, the benefit of this patient is so low with hormone therapy. Take example, you have a metastatic breast cancer, patient is ER positive to the 5%, you have few liver deposits. Would you be comfortable doing single agent hormone therapy for such a patient? My quick answer will be, I am not very confident, because in a very, very low ER single positive, I would be very skeptical. I will probably err towards the side of chemotherapy. That's my implication of this report. If this hormone receptor would have been 40-50% positive, maybe 25% positive, I would not have thought twice before offering the patient, except for those in a vessel crisis. In the adjuvant, all of us have to give it because the law mandates that anyone beyond 1% should receive. But the value of the benefit of that in that 1 to 10% is very, very skeptical. So that's the point of how do I interpret this report. Is 1% positive relevant? In the lab, yes, it is. In the clinics, it is questionable, and you have to look at other parameters before you take a call on that. And that is already there if you look at the antibodies, that is different antibodies which is used, and look at the Aldred score or the other things. If you very clearly tell, all of you them will tell you till 9% it is weak. Be 10 and beyond, that's where the positivity really starts off. That's where the activity really picks up. Also, you have to look into whether the lab which you are sending the report is important, because are they validating themselves frequently. Because here it is told in ASCO, a mandatory participation in external proficiency testing program at least twice a year. That's what it is. Continuous upgradement, what we are doing with this module probably. Look at the HER2 new reporting. We look at the percentage. We look at here there is no internal control, mind you. It is only external control, and that external control is a high grade ductal carcinoma in situ, frequently have HER2 positives, and that could serve as a positive control. Here, the most important is to look at the invasive component only. Don't look beyond invasive component, but the most important interpretation, we have HER2 testing done in stomach cancer. The staining and the pickup of the staining of a stomach cancer is so very different, but how you look at the breast cancer. It is not that uniform, not that dark, deep, and the staining, if it is incomplete also, you still in a stomach cancer interpret as a positive report. The 1 plus 0, 2 plus 3 plus is same as in the breast cancer, but the type of staining, the pattern of staining just changes in the stomach cancer. That's why for a stomach cancer HER2 reporting in ISC, you need a person who's much more better, who is trained in that, because sometimes people do not report and reports can be erroneous. Last part of it, if you are really treating stomach cancer, to look at the TOGA trial and look at the other trials in which are done in this setting. If you have a patient of a 0 or 1 plus HER2 on IHC, if you do IHC FISH, still 7 to 8% turn out to be FISH amplified. So be careful if you're really into it. If you want to give that patient the best chance, nothing stops you. Although recommendations are different, the implications of clinics are different. I would not hesitate for the patients with deep pocket to go ahead and do the HER2 by a FISH, even if they are 0 or 1 plus. The third part of the breast cancer, what we are gradually developing is the risk stratify the adjuvant therapy. And this is the Oncotype DX. This is from the TELREX trial. All of us know in the postmenopausal, very clear, the low grade, the intermediate do not offer chemotherapy, does not help. High grade offer chemotherapy. But I would interpret in a premenopausal, probably younger patient, even in the high intermediate scores, I will probably give chemo, because the benefit of chemotherapy is additional to the benefit of hormone. But with the age, it changes. In the elderly, I would not. But in the young, I probably will go beyond 16 and give chemotherapy. If there's a mamma print here, if someone has done it, this is how it is. The red is the -1 to 0 is the high risk. The 0 to 1, the green is the low risk. And that it is that we all do this. But the most important implication is, this is the MINDAC trial. This included patients who were hormone positive all patients hormone positive, but included patients who were both pre and post menopausal, but most importantly, took patients who had up to 3 nodes positive. So if you have a node positive, someone does not want to risk stratify himself, you should go for a mamma print, because that is where the nodes comes into, and you have high quality data, because they had taken patients up to 3 nodes. So now shifting gears. The second most what we do in a practice is the CML, the BCR-ABL. We just read a BCR-ABL. Even I used to do that mistake and look at it. Okay, this is just ABL report. I look the positivity, negativity, the percentage. That's all. Should we be doing that? Is there something more which we need to look into this? A diagnosis, should we be doing a quantitative or qualitative? I think a qualitative is fine. That's what the ELN guidelines tells you. You need not quantify at baseline. It's not required. A cytogenetics by FISH is good enough. If you are doing a cytogenetics routine, it is mandatory, but you just need a qualitative. But the most important, what I want to tell you is baseline is, You have to look if you are doing a BCR-ABL by the RTBCR. Is it also looking at the variant? What the BCR-ABL transcripts are it looking at? Because we commonly look at three transcript levels: 170, 190, 210, or something. Some people look at 230, 210, 190. Are we looking at the rare BCR-ABL transcripts or the atypical BCR breakpoints? I'll tell you why it's more important. If you are not looking at that and you have a major typical BCR-ABL transcript, then you probably can follow these patients for a TFR event. But if you are not quantifying the which type of BCR-ABL transcript was there, if you are not documented, I did a mistake which I learned from here. This patient came to me with a BCR-ABL fusion positive by FISH. 3 months, I did a BCR-ABL. This time, a quantitative RNA transcript level, it was 0%. I was thrilled, and I just missed the game here. The patient went on to get the zero for the next 3 years. I offered TFR, was on nilotinib, and after 1.5 years, the counts started rising. The BCR-ABL mRNA transcript was still 0. I did a FISH, it was positive. So what it tells me that, and then I went on to do a multiplex panel, and we did find that we had a atypical BCR-ABL transcript, and that was not the ideal case for a TFR. Luckily, the patient has come back to remission, but that was a mistake which we need to avoid, and that's how we interpret the reports. And now coming to this, is this report okay? Guys, look at this report. You have a BCR-ABL mRNA transcript of 0.1152. Fine, good enough. 3rd month of therapy, lovely. No, I think everything is not okay with the report. What is more important is when we're looking at this report, also look at the transcript level of the ABL copies. That's what I mean. Look at the transcript level of ABL copies along with this. Then only you can quantify your MRs. It is MR4, MR4.5, or MR5. And that is what it, because the ABL copy indicates the quality of RNA. Was it adequate to accurately report that result? If I'm looking at this, and if my reports have ABL copy of beyond 32, and my patient has achieved a MMR 4.5 of 0 transcript, I'll be pretty happy. With the 0 transcript, if a 20,000 BCR-ABL copies are there, I could not quote it as MR 4.5. It can be at best MR4. So that's also something we all of us need to look into. Now look at one more report. Interpretation of the report with the increasing titer, very steady control, and just then the titer goes up. Normally, all of us know we normally go for a 2 to 3 titers in a frequent period of 1 to 2 months. If there is a rising titer, hematologically still in remission, I would not hesitate to do a mutational analysis. You catch up the disease early when the drug is not responding, and all of us know what to do after that. That's so much very important for us to see that small report which comes into our hand to see what else, what we really need to look into that report. Now shifting gears, now we're looking at the lung cancer. And the lung cancer, who should be undergoing molecular testing? And if you look at it, everyone who has adenocarcinoma component should be looking at the thing that, okay, I will be looking at the lung cancer and I'll be doing a oncodriver mutation. If you have a mixed component, please look at it and find that, okay, in the mixed component also, I will be doing, there is a adenosquamous. So any component beyond 10%, it will be adenosquamous. So I have adeno or squamous, at least 10% of both. You should be doing a molecular testing, because depending upon the percentage of adenocarcinoma, if it is much more, the molecular testing will play in tune with the normal adenocarcinomas. So that how to treat it, if I have adenosquamous, go into details of it, treat as you normally treat adenocarcinoma. Mutation analysis, if there's a mutation, treat the mutation. If there's no mutation, treat as you normally do not do. For squamous cell, PDL1 is the only thing what you do. PDL1, until now, whatever told, IHC is the gold standard. I would not accept any other reports as of now, but others, broad NGS based panel is good enough. So here is example. One patient of mine, very well to do, everything is affordable. We did a spot gene mutation, what we normally do, and that was a ARMS PCR, a good technology. 18, 19, 20, 21 exons was looked into. It was normal. We did a NGS, it picked up exon 20. Same patient, same lab. And then to confirm, we send it to Foundation Medicine, because we had to confirm, because It was a big shot of my country, state. So this we found, and then we found exon 20 insertion here. So one thing, two things here. I found that Indian labs are good enough. I was very happy with that. Second, we found the same thing happening. So how does it, what does it matter? If I go back, this no mutation, I would have planned a immunotherapy and a chemotherapy. With this reports, my immunotherapy goes out. There is no role of immunotherapy if you have a mutation driver. That's the difference if how I should be looking at a test, and I should be offering the best technologies and platforms. NGS, most popular, probably solution is what we need. Not all markers are possible. Not all are approved. Be skeptical of this method. You still could miss a lot of it. Broad panel based approach preferred. RNA based NGS for fusion events are better than DNA based. It may pick up rare and concurrent mutations. We have patients who are having double mutations, and we need to treat them in a very unique way. RTBCR is for specific mutations. Sanger, spoken last time, you need a good amount of tumor enrichment, 20 to 30%. It is not ideal when you're looking at a progressive patient. It is not ideal for resistant mutations. FISH for amplification, number of copies and gene rearrangement. EGFR, which technique? You could use anything. But the point take home is if you use Sanger, it is negative. Do not hesitate to repeat with a more sensitive platform. One more interesting thing, are all exon 20 same? It's a beautiful thing that this mutation of exon 20 happens in 5% of exon 20 mutations. And look at it. This actually responds to the TKIs. And look at the response rate. It responds to a tune of 60%. What you normally find in all EGFR TKIs for 18, 19, 21. For 19 and 21. This is the typicality interpretation of everything. Just exon 20 is not good enough. Look at what in exon 20, and then you could have something very, very different, and you could have this mutation which is sensitive to TKIs. T790M at baseline. What I have already told, and people do discuss, I will start osimertinib. Is there a hard data to that? I'm sorry, I could not find. If Ullas is there, Dr. Parikh is there, they can help me in finding. But for sure, this points towards a familial lung cancer predisposition. Go to NCCN guidelines. You have to look at the familial lung cancer predisposition if you are finding osimertinib T790 mutation at baseline. Rare mutations, afatinib, easy choice actually. ALK, I'm skipping. We have done this. IHC is good enough, but PCR unlikely to detect fusions. For Roche, if you are doing IHC, it's low specificity. Confirm with Roche, confirm with FISH. Otherwise, do not start drugs. These are newer things which are coming up. NGS is preferred, but I'll stop for 10 seconds here. KRAS mutation. If you have a KRAS mutation, actually you should be not testing for others. That's what it is. It is mutually exclusive, the other mutations. But still, you could find 4 to 5% of patients having other mutations. But now the platform is, now we are getting the options. Probably in the future, we will do a KRAS. If it is mutated in 25%, it is mutated. You probably need not do the other thing. But still, as of now, you might test the other things. Last part of it before the BRCA comes in. PDL1, the in thing. What value is good enough? Look at this. I've taken a picture from the lung cancer. It is across trials. Look at the cutoffs. There are different cutoffs. All of us know these cutoffs. I'm not going to bother you with that. But as a clinician, we need to look at the tumor sites and the benefit at different levels of expression. Means if I have a stomach cancer, I want to use Pembro, I will be more inclined to use Pembro when the CPS is beyond 10%. If you need to use Pembro in head and neck cancer, the benefit is more when it is beyond 20%, although I am approved to use single agent Pembro at 1%. That's the beauty of this. You just do not look at the report, look at the benefit the patient will take, which assay is very, very important. SP263, if it's taken, is concordant with 22C3 and 28.8, but not with SP142. All are reported as TPS, while SP142 as IC. Companion diagnostics for Pembro for 22C3 and Nivo for 28.8 is the most appropriate, but you probably SP263 is good enough, except for Atizo. But lab developed tests, few of the labs do it, but if done, they have stringent criteria. Last, you know the CPS is for head and neck and stomach. You look into these data. For CPS, the reporting is very different from TPS. For lung cancer, most of the data is for TPS. So we as clinicians have to know this difference also. A small case, PET scan, lung mets with a large locoregional relapse bordering on carotid vessels. And This patient has CPS 2%. This patient has a large locoregional relapse, sitting on the carotid, lung mets, a Supreme Court lawyer, very rich, can afford anything. What do? You look at it. Should I consider pembrolizumab? The point is, if you look at the subset analysis and look at the forest plot for recurrent disease, the immunotherapy do not do that well. For a large bulky tumors, if you look at the immunotherapy data, single agent, the progression is 30 to 40%. So be very, very skeptical. There could be a huge progression. So for bulky disease, I think immunotherapy is not a good choice. If given, it should be given with chemotherapy. But cetuximab and chemotherapy is a better choice. So my point of take home is, this is where the curves separate after 6 to 8 months. So you have to be very skeptical for a bulky local regional disease. So does CPS matter or TP, the PDL matter? Yes. For higher scores, the benefit of the immunotherapy is better. All of us know that. So my choice for this would be the extreme regimen. So last step, BRCA mutations. We all do this. This is a pathogenic mutation. But take this example. This is a non-pathogenic, but this person has a family history strong of having a breast cancer. What do I do? Do I sit with this NGS report? No, I need to add the MLPA analysis because it rules out large deletions and duplications which sometimes the NGS misses. So we need to know the technology. We need to interpret the technology. We have to look at the family history. That's what it is. And the last slide is the VUS. The one thing that comes in is it is updated with newer information. Means once a VUS today is necessarily, it may turn out to be pathogenic after some years. I need the help of Dr. Parikh maybe in the discussion that do we as clinicians have the onus to tell to the patient after 2 to 3 years if the patient has done under us, if a VUS turns into pathogenicity, are we responsible to inform the patient? That's something also which lurks in our minds. Are we responsible? But remember, as the number of BRCAs testing are being done, the percentage of VUS are coming down. So to conclude, we need to update our knowledge, and that's so very important. Should usually have clinical implications. Whatever you do could be for research, that's a different thing. You should be bearing the finances, not the patient. But if the patient is bearing the finances, it should have an implication on him or her. Choose your lab carefully. Look at the lab, look at the standardization, look at the NABL, look at the CAP accreditation, look whether they are looking at the controls, look the reporting techniques. You can ask them. They should not be hiding data. They should be providing you data. Counsel the patient well, because it does matter. You are not going to cure most of your patients because most of our medical oncologists deal with stage 4. So counseling is so very important, or early cancers also can relapse. That's something which I want to end off with. They say knowledge is power, but more powerful than knowledge, understanding. So what I meant was understanding that piece of paper which comes to you is so important. You may have read the best of journals, but understanding the report, interpreting for the patient is something, if you do, then only you can breach the barrier and probably can do much better for your patients. So thank you. Thank you for a patient listening.
Uh, Thanks, Sahu sir, for a very precise talk with lot of take-home messages. In the meantime, we can have a question answer session. I think we can share the post-session questionnaire link can be shared in the chat box. So we
Before
had
that, can I ask sir that question which I asked? And that's a good question
yes
which I
sir,
had.
yes sir. Sir, you are muted, sir. Yeah.
Sir, Sahu, your question was that if there is a patient whose report says VUS,
Yeah.
is it the responsibility of the medical oncologist or the treating physician to interrogate publicly available databases at regular intervals and
Yeah.
identify?
Yeah.
So at present, it is not our responsibility to interrogate.
Okay.
But if the lab sends a revised update report and says that this is now it is being assigned causality, it is pathological. If the lab sends us a revised report, then it is our responsibility to forward it to the patient.
To communicate with the patient. Okay, sir. Done. Thank you, sir.
So should we be calling the patient for follow-ups periodically to check whether the VUS becomes pathogenic or not, or we need not have to follow up just for checking
So,
VUS?
if I got it correct, Purvish told that if a lab has communicated with you and has changed the VUS to a pathogenicity, It is the
Okay.
onus on us then to report back to the patient and put it to the patient's knowledge. That's what I got from sir.
Okay.
Yes, yes, absolutely right. The other thing that we could do from medical legal point of view is to write in the discharge summary that the patient should be in touch with the lab at regular
Yeah,
intervals to identify whether the VOS has changed.
yeah,
Then the
that's a good
onus
one,
is
sir.
shifted to the lab rather than being on us.
Okay. So just to complete further more questions, how sir the questions are there. So you said that a lab may be NABL accredited, but we don't know whether that lab has the particular test under the NABL accreditation. So how do we actually know that? Maybe how sir, Purvish sir, anybody can answer. This is sort of a uh,
Actually,
So,
it is quite easy. We need to communicate. Sorry, sir. Please, sir. Please.
Janai, Sahu, please continue.
Yeah. So it is important for us to just talk to the person in the lab because this happens very commonly. Because NABL, when they to tell it is that NABL, we just think that everything what they do is NABL. But there are a lot of things which are in the scope of NABL and something which are not in the scope of NABL. And that's normally written in a very small print somewhere. So you need to communicate with your lab because the onus is on us as physicians. So sometimes they spend a huge lot of money on our recommendations. So I think we have to speak, our lab persons have to communicate. And if they do it, I think you will know which are accredited for which things and how do they have that control thing that if do they do their regular monitoring of the controls of do their external control checks with some other labs annually twice at least. That's also so important. You as clinicians have the right to get the report. That's what my take was.
So these are two very important points that Sahu has brought out, and I would like to reiterate. One is that the labs will claim that they are accredited. It is not the lab that is accredited, it is the test in the lab that is accredited. So we have to ask, is this particular test accredited or not? And the other is quality assurance. So what Sahu mentioned is an informal type of quality assurance where labs can exchange uh, unmarked samples and then identify whether their reports are matching or not. Many labs take part in a formal EQUAS program or external quality assurance program, which is both regional in Asia as well as international. And if they are doing that, then we can be more reassured about the quality of whatever they're
okay.
So
So
how low is the
yeah.
ERPR?
So you were just mentioning, sir, whether it
Yeah,
is 1 plus 2 plus 3, just to figure
Uh,
out
so,
when to
so, so,
choose what.
so if you look at there are two types of getting, we get it in percentage and we get it in all rates. So if it is the percentage, I think anything beyond 1% for the legal issues, you have to offer it for whatever benefit. The data tells us that if the patient is not receiving any chemotherapy, even more than 1% in adjuvant, there is a benefit. But what I meant in the metastatic setting for a low ERPR, be skeptical if you are just having even some visceral disease, be very skeptical of starting a single agent hormone therapy. Although you cannot deny this benefit to the adjuvant patients. Legally, you are doing it, but on practical issues, all of us believe that beyond 10% is where 10% and more is something which you are looking at is more of the patients will respond to the hormone therapy. That's what my take was.
Okay. So just a follow up, Dr. Wolfat was just asking in 1 to 9, should we offer only hormonal therapy?
For a metastatic, I look at the scenario. If I have only bony mets, very low volume disease, if the patient is skeptical for chemo, I would give it. I take a scenario of a visceral disease, liver
Okay. Okay.
deposits not in crisis, I'll be very skeptical.
Fine, sir. Okay. You can quickly go through further questions. Yeah. So I think that was very well presented, sir. We all have done this mistake. So what do you think, sir? Should we be mentioning the type of transcript in every RQPCR, BCR ABL test, or what do you think?
Yeah, yes. I think there are two aspects which I told actually. One thing is the baseline. Look at what was the BCR able transcript. If there is a typical BCR able transcript, then only you can offer TFR or you can follow the patient very, very carefully. If there is not, be skeptical. These patients are not fit for ideally for TFR. Second thing is for measuring the depth of the remission. I think the ABL copies are so important. You just cannot do without that.
Perfect. Perfect, sir. So the next one is on the screen. So anybody who has experience of BRAF on IHC.
Ullas is there. Ullas will be there. He's due for me.
Okay.
Ullas,
Yeah, sir. Hi.
please
Hi,
answer
sir.
this.
Yeah.
Now,
The question is, do you have experience on BRAF IHC in lung cancer?
no. No.
So it's very clear. Yeah.
Okay, next.
So we are looking more of the NGS platform.
So when do you want to do
So,
MLPA for BRCA?
Can I comment on
Yeah,
that,
yeah,
sir?
yeah. Yes, sir.
Okay, so BRAF is basically, again, BRAF is not a simple BRAF. BRAF has to be V600E and non-V600E also. And to be very honest, in lung cancer, it's only BRAF V600E for which against dabrafenib trametinib is, kind of approved. So we also, as the discussion going on, we have to look at all the mutations in detail about what exactly is the report looking over there, not just blindly BRAF है कि नहीं है and give the treatment.
Yeah.
So
So yes, the IHC clone is available.
but it is not the standard test over there. There can be a lot of things which can go wrong with that.
Yeah,
That's mine.
even for the Roche, the IHC is there, but Roche one, but you need to reconfirm. That's what the take-home message was.
By fish.
Yeah. So for this Chandrakanth, the BRCA for the MLPA, my take home was that you have to look at the family history very carefully. Just with the NGS, it is not just good enough to just tell no. What I would do for a strong family history, I would not hesitate to do MLPA. But if you are doing both platforms, then you would not be missing the large deletions and the duplications, additions. That's my take was that. So you would not just go with one report.